Okay. Hi, my name is, hello, Dr. Donaldson. My name is Duncan Andrus, a pharmacist. I'm here to help recommend an empiric antibiotic regimen for patient Margaret Nielsen, date of birth 2/7/1968. The patient is a 56-year-old female with a chief complaint of, I had an ingrown toenail that became infected several weeks ago, and now the whole foot is swollen. She had complaints of sore and swollen foot in the ED as well. And then 3 weeks ago, her right toe became swollen and red from an ingrown toenail. She tried to fix it with scissors and tweezers, but the swelling just got worse. And then a thick, foul-smelling drainage became noticeable about 2 weeks ago. The patient's past medical history includes type 2 diabetes for 16 years, hypertension for 14 years, hyperlipidemia for 14 years, and then chronic renal insufficiency stage 3, as well as a surgical history of cholecystectomy that was performed in 2011. And her mother and father both had diabetes. Her father passed away at 78 from complications of a stroke, and her mother at age 77, secondary to colon cancer. The patient lives at home with spouse and their youngest child, non-smoker, but does drink occasional alcohol, denies illicit drug use, and then she works as a legal assistant. Her home meds include telmisartan 80 milligrams daily, amlodipine 10 milligrams daily, dulaglutide 3 milligrams weekly, and empagliflozin 25 milligrams daily, atorvastatin daily, multivitamin daily, calcium daily, and a melatonin daily at bedtime. And then for inpatient meds, she was started on Lantus 20 units sub-Q daily to work on that glucose that was a little elevated, and heparin 40 milligrams sub-Q daily, as well as a lactated ringer, 1 liter in the ER and 1 liter in the OR. Her vitals include a temperature of 37.8, a heart rate of 80, respiratory rate of 18. Her O2 sats are 93% on room air, blood pressure is 132/70, weight's 88 kilograms, and height is 5'3". Physical exam was all normal except extremities and neurological. So the extremities showed 2+ edema with markedly diminished sensation of the right foot, warm to touch, erythema, swelling, and induration extend between the first metatarsal to the midfoot. So that was 3 centimeters by 3 centimeters. And then that was confirmed. The physical exam also confirmed the purulent, foul-smelling drainage expressed from the great toe wound. And then the wound probe went 2 centimeters deep, and there was pedal pulses, but they were diminished, and a normal range of motion, and then poor nail care with some fungus and overgrown toenails was noted. Neurological function showed alert and oriented, time, place, and person. Sensory system exam showed a decreased sensation to light touch of the lower extremities, so both feet, and then intact upper body sensation, so just the feet. Pertinent labs include a white blood cell count of 16.8 with neutrophils 76%, band 6%, lymphocytes 12%, hemoglobin of 14.5, a hematocrit of 44.4, glucose of 297, BUN of 38, a serum creatinine of 1.52, and her baseline was 1.3, and then a hemoglobin A1C of 9.2%. And then her C-reactive protein was 112, and her procalcitonin was 2.2. All of her other labs were either within normal limits or not pertinent. So the nasal screen for MRSA is still pending. The blood cultures are pending, and the tissue cultures obtained in the OR of the right toe are still pending. The X-ray that was done shows there is soft tissue swelling from the first metatarsal to the midfoot, consistent with cellulitis, and then there was no fluid collection noted, and no evidence of adjacent periosteal reactions or erosions to suggest radiographic evidence of osteomyelitis. And then no definite subcutaneous errors evident, presence of vascular calcifications. As for assessment, the patient has a visible sore on the right foot with a thick, foul-smelling drainage and an elevated white blood cell count, with an increased neutrophils, which indicates a bacterial foot infection. The physical exam, limited response to stimulus on the foot, the neuropathy, the impaired pedal pulses, the poor foot and nail care, as well as the history of diabetes suggests that this is a diabetic foot infection. The size and depth of the wound indicates that it's a moderate diabetic foot infection in nature. The sepsis is not likely based on she just has one of the SIRS criteria met with the white blood cell count. And then osteomyelitis is not likely based on the X-ray findings. This evidence supports the labeling of this disease state as an acute, new onset, moderate, uncomplicated diabetic foot infection of the right big toe. And then the patient doesn't have any evidence of complicating factors such as like a warm climate, ischemic necrosis, gas, recent hospitalization, or recent antibiotic use. We do have some goals. So for short term, we want to resolve the diabetic foot infection and prevent complications of the foot infection, as well as prevent adverse effects of the antibiotic therapy. And then for long-term goals, I'd like to prevent the recurrence of the diabetic foot infection and provide the patient with resources for proper foot care. And then with no complicating factors, we're just going to be using coverage for strep, staph, and gram-negative rods. The empiric therapy without complications for diabetic foot infection is either a beta-lactam with beta-lactamase inhibitor or a second or third generation cephalosporin. And then IV therapy is preferred since this is an inpatient treatment. And so that leaves us with Unison or ceftriaxone as our IV antibiotics that would usually be on a formulary. So ceftriaxone is dosed less frequently, which makes it the preferred option. Lexicon recommends a dose of 1 to 2 grams per day. The 2023 IDGDF IDSA guidelines recommend a course of therapy of 10 days following irrigation and debridement. The patient just had the irrigation and debridement today, so my recommendation is to initiate empiric therapy with 1 gram of ceftriaxone infused daily for 10 days. And then once the cultures come back, antibiotic therapy should be tailored to finish that 10 days with whatever the culture is susceptible to. And then as well as if the patient is discharged in that 10 days, they can be switched to an oral regimen when they're discharged. And then for follow-up, I'd like to refer the patient to a diabetic foot care team just to follow up after the surgical debridement, and then refer to wound care every 2 to 4 hours to assess that wound, or even the nursing staff should be following up every 2 to 4 hours as well. They can kind of work together to assess that. And then the patient should be referred to a podiatrist or their PCP, outpatient, just for proper foot care and diabetes management. And then vitals should be checked continuously and then assessed every 2 to 4 hours. And then white blood cell count, a C-reactive protein, and a procalcitonin should be assessed daily, as well as an MRI should be considered if there's no improvement or if the infection gets worse. And then just monitor for drainage, odor, or worsening infection every 2 to 4 hours. And then assess the SIRS criteria every 2 to 4 hours as well, to ensure the patient isn't developing a systemic infection. Those are my recommendations. Would you like me to put in an order, or do you have any questions for me?
No, I think you've got it all. Can you tell me you can go ahead and stop your recording.